Good evening, everyone. I'm Lawrence Lloyd, the Medical Science Liaison from Novartis. First of all, on behalf of Novartis, I'd like to thank all of you for taking your time off to join us here today for this year Primary Care Summit. And it's a pleasure that this year we are able to invite two eminent speakers, namely Dr. Rafida and Dr. Ika, to join us here in this year's summit. Dr. Rafida is our consultant cardiologist from Institute Jantung Negara, where she has graduated from Ireland and later did her subspecialty training in cardiac imaging. She has various memberships such as American Society of Echocardiography, British Society of Echocardiography, and the European Association of Cardiovascular Imaging, to name a few. Dr. Ikai, who is our second speaker, is our consultant cardiologist from KPJ Ampang Puteri, Kuala Lumpur. She is also graduated from the University of Liverpool in 2002 and later received her specialty degree MRCP from the Royal College of Physicians in Glasgow in 2007. She did her specialty training in IGN later, and then her specialty interests include heart failure and also general cardiology. Without further ado, I would like to pass the floor to Dr. Rafida for the first session. Thank you very much.
Thank you very much, Lawrence, for the kind introductions. Good evening, everyone. So the topic that we'll be discussing today for the first session will be diagnosis of heart failure. Diagnosis of heart failure. Knowing the essential. So this is your typical case. Mrs. AG is a 65-year-old lady with background history of type 2 diabetes mellitus and hypertension. So she presented to you with breathlessness. On examination, you auscultated the lung and you could hear that there is bibasal crackles, and there is also minimal lower limb edema. So this is what she said to you. I feel breathless over the past 1 month. I cannot lie flat at night. It has worsened over the past 2 days, and my legs are now very swollen. What is wrong with me, doctor? So in this case, what would be the most likely diagnosis? And my next question would be, what would you do next? Would you start the furosemide? Request for chest X-ray? Request for BNP or NT-proBNP? Refer straight to cardiology service for echo and full cardiac work? Or you can opt for all of the above.
The poll is now open. You may make your selection. The poll is now closed. 69% chose all of the above. 19% chose chest X-ray. 6% chose start furosemide, and 6% chose refer to cardiology.
Okay, that's very good. Of course, when you have a patient like this, first thing first, you would need to start the patient on the treatment. Because if, let's say, you refer the patient straight to cardiology, it may take some time, or a few hours. So what you need to do is that you need to start the patient on treatment. If you have access for chest X-ray, you can do it straight away. And at the same time, of course, you should refer the patient to cardiology. So what is heart failure? So this is the diagram of the normal heart. Display. I don't have anything on the screen.
Good evening, Dr. Ika. At the meantime, while they are solving the technical glitch, it is possible that if you could share with us what is the rationale of using biomarker, typically NT-proBNP or BNP, in helping to assist in the diagnosis of heart failure in an acute setting?
Oh, I've used BMP quite extensively, simply because it helped me to titrate my anti-failure medication and also to see if my patient is improving or not. Because you can't really do echocardiogram every time the patient come and see you, and then also the fact that BMP is pretty fast in our hospital. We can get it within an hour. So it's being used extensively, and it really correlates from my experience based on the clinical finding of the cardiac remodeling as well as symptoms.
Okay. Thank you very much, Dr. Ika.
Rafida is back. Okay.
Yes. Yes. So I'll pass the floor back to you, Dr. Rafida.
Are we on track? Yeah, it's fine. You're back on track. That's brilliant. So basically, when we talk about heart failure, what we want to know is that we want to know whether or not the structure is normal or not. So it's like, say a patient has a normal structure, the LV size is normal, and then the LV function is normal as well. Whereas in the case of heart failure, what you have is that you have dilated left ventricle, and sometimes you could get the dilated right ventricle as well. And then, of course, in this case, you can see that there is a reduction in the ejection fraction. You have heard about heart failure reduced ejection fraction, heart failure kind of moderate reduced ejection fraction, as well heart failure preserved ejection fraction. So we'll be talking about these later in the slides. So what causes heart failure? So there are multiple causes of heart failure. So the most common thing, well, for patients who are referred to IJN, are coronary artery disease. And then sometimes you can have problem with the heart muscle itself. So if let's say you have left ventricular non-compaction, whereas you have trabecular left ventricle, which cause reduction in the ejection fraction after quite some time, you could get heart failure with that as well. And then towards the end, you may get thrombus. And then you could get hypertrophic cardiomyopathy. So would the patient with hypertrophic cardiomyopathy get kind of LV dysfunction straight away? The answer to that is no. Usually toward the end stage of hypertrophic cardiomyopathy, they would get kind of heart failure symptoms. And then sometimes some patient has heart defect at birth. It could be either what we call that ASD, VSD, or TOF. Patient who had heart attack. So basically, if let's say they presented to the hospital quite late, these are the patients who had infarcted myocardium, and as a result of that, they have kind of non-viable myocardium that cause a reduction in the ejection fraction. Hypertension could cause heart failure as well, but this one usually will be associated with heart failure preserved ejection fraction. Okay, leaky valve. So if let's say you have severe mitral regurgitation and it's not treated, or it's not detected very early, you may present with heart failure symptoms. The symptoms would be breathlessness at rest, and then you could get swollen legs, and then the patient may have orthopnea as well. Okay, diabetes mellitus. Well, diabetic cardiomyopathy is actually a diagnosis of exclusion, so you have to exclude all other causes before you can make the diagnosis of diabetic cardiomyopathy. So when you get heart attack, what happens is that if, let's say, your coronary artery is occluded for more, for example, for more than 12 hours, what would happen is that you could get scar within the myocardium affected. And then in Malaysia, the problem that we have is that most of the patients would present quite late to the hospital, which means sometimes they may have the heart attack probably a few days beforehand, but then because they think that was nothing, they decided to stay at home. And then they only would present to the hospital when they started getting very breathless. So for this, for presentation with heart attack, I think what we need to do is that we need to create more awareness among Malaysians, so that whenever they have any symptom, for example, if they say they have chest pain on exertion, they should actually go and see their general practitioner and have it investigated, rather than wait for quite some time and then present it only when they have kind of significant failure symptoms. So what is the prevalence of heart failure in Southeast Asia? So for the acute decompensated heart failure, the mean age for patients who presented in Southeast Asia is 55 years old in comparison to 75 years old in USA. And then they also look at the length of stay for the patient who are admitted with acute decompensated heart failure, and they notice that the length of stay for patients in Asia is slightly longer compared to the patients in the United States. So 6 days versus 4.2 days. And then the in-hospital mortality as well is higher compared to USA, 4.8 versus 3%. And they also look at the stable heart failure. So this is actually from the Asian HF registry. So for the Asian patient with heart failure, the mean age for presentation for this patient is 59.6, so roughly about 60 years old, with 2/3 of them age less than 65 years old. So this is actually quite early if let's say you compare to our American or European kind of patients. And again, Asian patient with stable heart failure present at least a decade younger compared to the European patients. So how about Malaysia? So 6 to 10% of admission in Malaysia is due to heart failure. So in a year, we have about 3 million admission, and of this, we estimate that about 300 of the hospital admission are due to heart failure. And then 25% of these patients were re-hospitalized within 30 days. So you can see the burden of heart failure in Malaysia. It's quite huge, 300,000 hospital admissions, and of this, a quarter of that re-hospitalized within 30 days. Now, when you have heart failure, if they say it's detected early, you may be able to prevent that from progressing. But what happened in Malaysia is that the patient may present quite late. At that time, the ejection fraction probably could be kind of severely reduced. For example, ejection fraction of 20-25%, and then they may at that time already develop kind of what do you call that? Kind of involvement of kidney as well. Okay, so when the patient comes in with heart failure, what we would do is that we would actually optimize their medication. We will give them diuretics, and after that, we'll start them on spironolactone. We also would start them either spironolactone or what you call it, eplerenone, and then you may consider adding ARNI as well. So this is the proportion of heart failure hospitalization across the globe. Okay, about 1 to 4% of hospital admission globally are due to heart failure. And then the average length of stay due to heart failure is about 5 to 10 days across the globe. And this is actually comparing mortality from heart failure in comparison to cancer for both male and female. So you can see here that mortality following admission for acute heart failure, here, the blue line here actually exceed most of the cancer. So it's actually more than breast cancer, bowel cancer, or ovarian cancer. And for male, is more than bladder, prostate, or bowel cancer. Again, this is actually looking at the 5-year survival rate for patients with heart failure. As you can see, the patient with heart failure, the mortality rate is as high as colorectal and bladder cancer. This is again looking at the comparative 5-year mortality rates of heart failure and variety of cancers in the United States. And you can see here for men, it's just under lung cancer, and for women, it's just under the ovarian cancer. Now, we talk about the signs and symptoms. So what would your patient complain to you? Most of the time, they will say that, doctor, I have been breathless for the past week or two. Doctor, I noticed that I can't lie flat anymore. I have to sit up if I say I want to sleep. And then they would get actually kind of breathless as well, even when they're sleeping. They would say that they will have a reduced exercise tolerance. When you see the patients, I think this is actually what we do on a daily basis. We'll look at whether or not they have swelling in the legs, and then we would look whether or not there is any raise in JVP. Of course, you would auscultate the lung, and in majority of the cases, you would hear that the patient have freckles. In some cases, if they say the heart failure is due to valvular regurgitation, you can hear murmur when you auscultate the heart. So when you see a patient, just think about this mnemonic. So basically phases, you would look at, ask the patient about tiredness, fatigue, about limitation of the activities, that is a reduced exercise tolerance. Chest congestion, of course, you need to auscultate the patient, and then you would look for sign of edema of the legs as well as the ankle. Now, diagnosis and management. I think everyone would be using this whenever you present to, or you kind of write a referral to your colleague. You would explain in the letter what is the functional status of the patient. You can either use the NYHA functional class, which I usually would do, or you can actually use the ACC-AHA stages of heart failure. So for this one, stage A, stage B, C, and D. So stage A is equivalent to class 1 NYHA functional status. I think majority of the time in this case, we usually would use the description of an NYHA functional class when we are referring patient to our colleague. Now, diagnostic pathway. So whenever a patient come in with symptoms of breathlessness, so what you need to do is that you need to take a proper clinical history, and then you examine the patient. If you have access to do ECG, then you can do the ECG, okay? If the clinical history, the patient say that they have breathlessness, but when you examine the patient doesn't have any clinical signs, then you may want to consider doing a pro-BNP, because if the pro-BNP is normal, then it's quite unlikely that the patient has heart failure. If you have access to echocardiography, of course, you should send the patient for echocardiography. If the echo is normal as well, then heart failure is unlikely and you need to consider another diagnosis. So sometimes it could be due to COPD, sometimes it could be due to hyper-airway reactive kind of syndrome. So you need to exclude that the reason for the breathlessness is due to heart failure. After that, you can actually kind of do other investigations. Okay, so this is the categories of heart failure. So you have the heart failure with preserved ejection fraction. By definition, this patient has ejection fraction of equal or more to 50%. Okay, to diagnose this, you need to have elevated BNP, and then you need to have at least one additional criteria, whether or not the patient has LVH. So of course you need to do the echo, and you need to see whether or not there is any enlargement of the left atrium as well. And then another thing is that you need to see whether or not there is any diastolic dysfunction. The second kind of type of heart failure is that heart failure with mid-range reduced ejection fraction. So that one, the ejection fraction is between 40 to 49%. Again, in this case, you need to make the diagnosis, you need to have elevated BNP, and then you also look at the structure. You have to see whether or not there is any LVH or enlargement of the atria, and then you also need to look at the diastolic dysfunction. And then the most common one that we see, especially for patients with ischemic heart disease, is the heart failure reduced ejection fraction. This would be in patients who presented quite late to the hospital when they have a STEMI, which means that the occluded coronary artery could be there for more than 24-48 hours, and the area supplied by the coronary artery is infarcted, and hence causing the reduction in the ejection fractions. These are the type of patients that would over time have a dilated LV. So this is the ESC guideline for treatment of patients with symptomatic heart failure reduced ejection fraction. So you need to do the echo. You have to establish that the ejection fraction is low. And then what you need to do is that you need to optimize the medication. So what medication should you add for the patient? Okay, so a patient with heart failure would be on diuretics, okay? They will also be on beta blocker, ACE or ARB, and then you can add either spironolactone or eplerenone, okay? Now, the most recent 2016 ESC guideline, they have recommended ARNI to replace ACE inhibitor. So ARNI is your Entresto, if they say they are able to tolerate ACE inhibitor. These are the landmark trials in patients with heart failure reduced ejection fraction. Over the past 10 years, these are the three big studies. So you have the SHIFT study, which recommend the use of ivermectin in patients with heart failure, as it kind of reduce the cardiovascular death or heart failure hospitalization by 18%. And then you also have the emphasis heart failure trial published in 2011, whereby the introduction of eplerenone would reduce cardiovascular mortality or heart failure hospitalization by 37%. And this is actually the new kid on the block. Not really the new kid, but I think we are only using it quite extensively over the past 2 to 3 years. So this is actually paradigm heart failure. So this is looking at the use of ARNI, which is Entresto, Sacubitril, Valsartan versus enalapril. And in this study, they kind of showed that cardiovascular mortality and heart failure hospitalization is reduced by 20% if you use ARNI, which is Entresto, in comparison to enalapril. Now, what is ARNI? Is angiotensin receptor, which is the Valsartan, and neprilysin inhibitor, which is the Sacubitril. So it is actually the name for Entresto. I think for the past 2 to 3 years, we are using it more frequently for our heart failure patients. I remember back 2 years ago, whenever we want to prescribe Entresto, we had to get the approval from our heart failure consultant, but nowadays you would be able to prescribe Entresto, provided that we have the appropriate indication for it. Now, how does it work? So basically, the Sacubitril inhibit the neprilysin inhibitor, and the Valsartan, of course, it actually inhibit the RAS kind of receptor. So basically, the combinations of neprilysin and the RAS suppression of the RAS inhibitor actually kind of help improve in the long-term outcome of patients with heart failure. So these are actually the effect of Sacubitril and Valsartan. So it actually reduced, for Valsartan, it actually reduced the sodium and water retention. And both of them actually reduced the left ventricular hypertrophy. It also reduced the aldosterone secretions. And it actually reduced the systemic vascular resistance as well, which is very important in the kind of treatment of a patient with heart failure. So we talk about paradigm heart failure. So I think everyone has heard about paradigm heart failure because if you are using Entresto, I think the reason why you use Entresto is because you're convinced by the outcome of this study. So what they're looking at is that they're looking, what they did is that they actually start the patient on Entresto. This patient needs to be in NYHA functional class 2 to 4, and then this patient needs to have ejection fraction less than 40%. So these are the key inclusion criteria for this study. NYHA functional class 2 and 4. Of course, if let's say the patient has only NYHA functional class 1, they're not really entitled for the Entresto for this study, and then the ejection fraction less than 40%. They also look at the pro-BNP. It has to be more than 150, okay, or more than 100 if let's say the patient is hospitalized. But I can tell you that majority of the time, if let's say the patient presents with heart failure, their pro-BNP usually will be in thousands, not in hundreds. And if let's say their ejection fraction is already less than 40%, usually their BNP or pro-BNP level will be higher than this. Okay, these patients need to be treated or need to be on the treatment for on ACE inhibitor or ARB and beta blocker for 4 weeks. And then after that, this patient should be considered to be given the aldosterone antagonist. Now, the evidence from paradigm heart failure, they noticed that for patients who were given the Entresto, they noticed that this patient has a significant and consistent reduction in the level of pro-BNP as compared to the enalapril cohort. So the red line is your enalapril group, and the green line is your Entresto group. You can see that persistently, this one is after 6 weeks, that the patients who's taking Entresto has a pro-BNP less than 1,000. They also look at the effect of Entresto, whether or not it actually reduce the death from any cardiovascular cause of hospitalization, and in this case that there is about 20% relative risk reductions in death as well as for hospitalization of heart failure, and the number needed to treat for you to prevent 1 death or 1 hospitalization is 21. They also looked at the overall reduction in cardiovascular death. So for the patient who were given Entresto, there is about 20% reduction in risk of cardiovascular death. And then they also looked at the risk of heart failure hospitalizations, and in this group of patients who were given Entresto, there is about 21% reduction. The number needed to treat in this case is 36 patients. So basically, if they say you give Entresto to 36 patients, you would be able to save a patient from readmitted to the hospital. So how soon does Entresto give the effect? So they noticed that from the paradigm heart failure trial, that the reduction in heart failure hospitalization with Entresto was evident within 30 days after randomization. So this is equivalent to 40% relative risk reductions of hospitalization. They also looked at the all-cause mortality. Again, as you can see, comparison between Entresto and enalapril. Entresto is the yellow line. You can see that there is 16% relative risk reduction of all-cause mortality in the patient who were in the Entresto group. Now we look at the progress in drug treatment for heart failure, reduced ejection fraction over the past 30 years. So about 30 years ago, in the 1980s, mid-1980s, early 1990s, we used ACE inhibitor. And then after that, over the years, we realized that the patient would benefit from addition of beta blocker as well as from MRA. Okay, so this will be the standard of treatment up to 2016 before we have the new guidelines. With the new guidelines from 2016, ARNI is recommended as one of the treatment for the heart failure to replace ACE or ARB. This is from our Malaysian guideline. Again, the diagnosis of heart failure is the same. So basically what you need to do is that you need to establish the clinical history. You need to make sure that there is what you call that significant findings on clinical examinations. And then based on that, you need to do the pro-BNP as well. And then for the treatment, you need to consider ACE, ARB, or ARNI, and then you need to put the patient on beta blocker. Our CPG guidelines is similar to ESC guidelines for heart failure. Now, when you look at the heart failure trial, so what you are looking at So basically, one thing is that you look at the reduction of NT-proBNP. Number two, you want to know whether or not the patient is getting better. So what you need to do is that you need to assess that objectively. So what they did in this study is that they looked at the 6-minute walking distance. And of course, there is a subjective assessment as well based on the quality of life questionnaire. So basically what you do in this case is that you give a questionnaire to the patient, and then you just based on the questionnaire, you see whether or not there is any improvement in the quality of life based on the patient's reply. So what is pro-BNP? So pro-BNP so basically what happened when you have heart failure is that when your LV is dilated, you would get volume expansions, and then you would also get the pressure overload, which induce the synthesis of precursor BNP. Okay, so this is the reason why when you do a pro-BNP in patient with heart failure symptoms, you could see that the level will be high. So this is actually the guidelines from the 2017 AHA heart failure management. So in this case, again, I think this is only repeating from what I have said from previously. What you need to do is that you need to establish whether or not the patient has the symptoms. Clinical examination, you need to know what is the patient functional class, and then what you need to do after that is that you need to check the pro-BNP, and you need to also establish the ejection fraction. In patient presenting with dyspnea, in order for you to exclude heart failure, pro-BNP is one of the best biomarker that you can use to exclude heart failure. Because if they say the pro-BNP or the BNP is normal, then heart failure is unlikely. So this is very important, especially in GP practice, because I know in GP practice you also have the point of care pro-BNP, which you can actually perform easily when a patient presents to you with heart failure. This is looking at the reduction of pro-BNP at 1 month, and a patient who actually has a lower pro-BNP has a a lower subsequent primary event, which is hospitalization or death. In non-acute heart failure patient, NT-proBNP of less than 1,000 is associated with better prognosis. And then if the pro-BNP is more than 1,000, it usually is associated with increased risk of death or hospitalization. From my experience, I can tell you a patient who presents with acute heart failure, they usually would have their pro-BNP in the level of 20 or 30,000. So that's common if, let's say, they present with acute heart failure. What I have observed is that one, you optimize the medications, and then once you add the Entresto, when you follow them up in your clinic after 2 weeks and 6 weeks, you can see that there is a significant reduction in the level of pro-BNP. They also look at the significant improvement of 6-minute walking distance with Entresto. And in this, they showed that there's a significant improvement in the 6-minute walking test. So basically, this is a patient with heart failure reduced ejection fraction. This is actually a case series of 5 patients. So they look at the walking distance for the patients at baseline, red, and then the green one will be at 1 month after the introduction of Entresto at full dose. When they say at full dose, it will be at 200 milligram twice a day. So you can see that for patient 1, 158, patient 2, 80, 126, 220, 60. At 1 month, you can see that there is at least 3 to 4-fold improvement in the walking distance. We actually observe this as well in clinical practice. They also look at the quality of life. So these are the other things that they assess in the paradigm heart failure. And they can see that there is a significant improvement in the quality of life when the patient were given the Entresto, answered the questionnaire. So basically, they say that they can do more physical activity and they are able to socialize more, when they started taking the Entresto, which means that that is actually an indicator that they're getting better. Okay, and then they can do as many activities as they can after they started taking Entresto. And again, this is a real world clinical practice looking at the quality of life again. They noticed that after 1 month of treatment with Entresto, the symptoms and limitation for the patient improve in this group of patients. Okay, with 1 out of 2 NYHA class 3 patients having functional class improvement reaching NYHA class 2 or 3. This is actually very good. I've seen this in clinical practice as well. A patient who could barely walk about 100 meters after introduction of Entresto, because we usually would follow up the patients on 6 weekly basis. In my practice, I usually would follow up the patient in 6 weekly basis if I need to titrate up the dose of Entresto. I noticed that they actually report a significant improvement in their functional class. Okay, if let's say you have the capacity to do the 6-minute walk distance, you can also look at that. Now, this is just looking again at the BNP and NT-proBNP as a marker in diagnosis of heart failure. So to diagnose heart failure, the NT-proBNP has to be above 125 and BNP above 35. This is again just looking at the recommendations on the use of proBNP and NT-proBNP. I think this is actually one of the biomarker. If I say you want to invest for your general practice, this will be one of the biomarker that you should invest in, as you can do it at the point of care. And it doesn't cost that much, and you can easily give the patient the diagnosis if they say they present with dyspneic symptoms. They also mentioned about the chest X-ray. Again, we know this chest X-ray is recommended to see if they say the patient any pulmonary congestions. And this is actually an example of chest X-ray. So in a patient with heart failure, sometimes you could see back swing, that is the alveolar edema, clear B lines. Majority of the cases, if they say they have a very bad heart failure, they will have pleural effusions. And then sometimes you can see the prominent upper lobe vessel, which would indicate that they have pulmonary congestions, and cardiomegaly, of course, because they have alveolar dilatation and reduction in ejection fraction. Okay, so this is actually an example of the chest X-ray. Okay, so you can see that there is curly B lines, and you can see that the heart size is very big as well. Now, this is actually a chest X-ray of a patient with a very bad heart failure. Okay, in this patient actually has a large pleural effusion bilaterally. I think you can appreciate that. Okay, I think this is actually a very obvious heart failure patients. Okay, and this is another patient with increased opacity within the right upper lobe. Okay, this is actually a patient with pulmonary edema, which predominantly observed within the right upper lobe. ACC 2017 expert consensus, they recommend the use of echocardiogram in the evaluations of incident of in the evaluation of ejection fraction, because you need to know what is the ejection fraction, because you need to actually group the patient whether or not it is heart failure reduced ejection fraction, mid-range ejection fractions, or heart failure preserved ejection fractions. You need to do the echo as well, because you need to look at the whether or not there is any valvular pathology, whether or not there is any regurgitation, mitral or aortic regurgitations. Wall thickness, because sometimes patients who present with heart failure may have amyloidosis, Okay, so these are the reason why you need to do the echo, because if they say the wall thickness is very thick, then you would be thinking, could this be something else? Could this be some sort of infiltrative cardiomyopathy? Once you have optimized the medical therapy for after 3 to 6 months, you may consider the patients, if they say they still has not improved, you may consider referring the patient for ICD. Again, this is what we do in clinical practice. Okay, this is actually just a recommendation for cardiac imaging. In this case, transthoracic echo is recommended to diagnose the 3 types of heart failure: reduced ejection fraction, mid-range ejection fraction, as well as heart failure preserved ejection fraction. Okay, so how to interpret the result in patient presented in acute setting? If they say it's less than 300, it's unlikely heart failure. If they say it's more than 450 under the age of 50 years old, or if they say it's more than 1,800, there's a definite under the age of 75 years old. So this is actually confirmation by imaging, chest X-ray, echo, as well as you do the BNP. So we have talked about the use of echo, the use of chest X-ray. So majority of the cases, whenever they're referred to us, most of the time we already have established the diagnosis of heart failure. Majority of the time they will have LV dysfunction. Usually what we would do when we see the patient is that first thing first, we need to make sure that it's not coronary artery disease. So what we do in that case is that we will do coronary angiogram. But what would happen if, let's say, the coronary angiogram showed normal coronaries? So what should we be thinking? So this is when cardiac MRI comes in. So this will be in the group of non-ischemic cardiomyopathy. You can use it for ischemic cardiomyopathy as well, because you want to assess the viability. For example, the patient has 3 vessel disease, has chronic total occlusion of the RCA and LAD. Ejection fraction is about 25%. So you want to know whether or not you need to revascularize the LAD and the RCA. So what you need to do is that you need the cardiac MRI to assess the viability, whether or not the LAD and the RCA territory are viable. If they are viable, then you would consider the patient for revas, either with bypass surgery or with PCI. But if they say it's non-viable, you may opt, for example, not to intervene, but to optimize the heart failure medication. And for the patient who has LV dysfunction, but the coronary angiogram showed normal coronaries, these are the type of patient who falls into the non-ischemic group. So from the non-ischemic group, you have lots of the list, okay? But usually when we look at that, at the causes of non-ischemic cardiomyopathy, the first thing that we would want to rule out is that whether or not there is any evidence of recent myocarditis, which means that could it be the raised in troponin, if let's say the patient is referred as non-STEMI, is due to myocarditis. So you usually would want to see whether or not there is any edema, or if they say there is any fibrosis, any scar on the myocardium. You need to see as well whether or not there is any evidence of LVNC. Okay, sometimes you can also diagnose, not really sometimes, if they say the patient has infiltrative cardiomyopathy, especially if they say the patient has cardiac amyloidosis, you can easily make the diagnosis based on cardiac MRI, because it has a specific abnormal gadolinium kinetics. And you also have another diagnosis as well, such as the stress-induced cardiomyopathy, peripartum cardiomyopathy, and tachycardia-induced cardiomyopathy. Of course, the diagnosis of non-ischemic dilated cardiomyopathy will only be made if the coronary angiogram showed normal coronaries. So this is an example of late-stage hypertrophic cardiomyopathy. You can appreciate that there is aneurysmal apex, okay? And the ejection fraction is reduced in this case. And this is actually an example of an extensive fibrosis in a patient with hypertrophic cardiomyopathy. And this is actually an end-stage left ventricular non-compactions. Okay, you hardly could see LV&C as bad as this. So usually when you do the cardiac MRI, you want to see whether or not the LV fibrillations, the ratio, the non-compacted to compacted myocardial ratio, whether or not is more than 2.3. But I think for this one, this is actually a very obvious case. Just by looking at that, you know that this patient has LV&C. And another one would be the stress-induced cardiomyopathy. For stress-induced cardiomyopathy, you can diagnose that based on echo, or if let's say you do the LV-gram when you do the coronary angiogram. This usually will be seen usually for female patients, usually after emotional stress, either death. I've seen one patient presented after she was involved in house fire. So, in summary, so these are the things that you should be looking at when you kind of see a patient who present with kind of heart failure. They usually will be complaining of shortness of breath, swelling of the legs. Some of them would say that they have lack of energy. They would have PND. They say that they will have difficulty sleeping at night due to breathing problem. Okay, in back or towards the end of the spectrum, you may get patients who came in with confusions. But again, if they say the patient come in with confusion, you need to rule out any other intracranial pathology. Patient sometimes may have ascites as well, okay, and then significant lower limb edema. So these are the key message. So history, and then you need to do investigation, ECG, chest X-ray, echo. You need to do pro-BNP, rule out whether or not there is any coronary artery disease, do coronary angiogram. If the patient has normal coronaries, then you should consider other imaging modalities such as cardiac MRI. So take home message, you should consider pro-BNP because it can actually help to distinguish cardiac cause from non-cardiac cause. In this case, if they say it's normal, it's definitely not heart failure. You should be thinking of something else. Could it be COPD, late onset asthma? Those are the things that you should be thinking of. Okay. And then another thing is that clinical suspicion of heart failure. If they say you suspect the patient has heart failure, you need to support that with objective clinical evidence as well. So you need to have an echo. You need to document whether or not there is any reduction in ejection fraction or whether or not there is a preserved ejection fractions. Okay. And then, of course, again, you need to know the reason for it. So either ischemic or non-ischemic. If you have access to do chest X-ray, you should actually use that because easily, if they say the patient has pulmonary congestion, you could obviously see that on the chest X-ray. Thank you.
Thank you, Dr. Rafida, for such an interesting and also extensive sharing with us. And right now, I'd like to pass the floor to Dr. Ika. Thank you so much.
Both the American Heart Association as well as the European Society of Cardiology have agreed that heart failure is actually an abnormality of both cardiac structure as well as functional cardiac changes. And both of these are actually driven histologically by changes in the molecular level due to primarily myocyte hypertrophy, apoptosis, as well as institutional changes. So what is actually adverse cardiac remodeling in dilated cardiomyopathy? So if you look at it here, this diagram shows a normal heart following an insult, such as like what Dr. Rafida just said. Cardiac remodeling will occur and will eventually lead to cardiomyopathy. So when cardiomyopathy occur, the ejection fraction or the cardiac output would be less, which resulted in increase in end systolic as well as end diastolic left ventricular volume, which then will dilate the mitral valve annulus and causing mitral regurgitation and also eventually increasing the left atrium volume. As you can see, one of the picture slide that Dr. Rafida showed on the MRI, it shows that one of the patients with dilated cardiomyopathy has huge left atrium. And in this case, our heart that has gone, if the patient's heart has gone undergo cardiac remodeling, it will change from an ellipsoidal shape into a more spherical shape, which is not good for cardiac output. We all know heart failure is an insidious disease that starts way before the first symptom. This diagram shows the progress of heart failure. So there's 4 stages of heart failure. The first 2 stages are relatively asymptomatic. Patient hardly any different to their normal self. So if they have an insult, their heart disease will start and their symptom will started to progress. Initially, their symptom was quite severe, but eventually with time they will recover. But if you see here, their recovery rate is just like a bouncing ball. It can never reach back to the same level that it started. So it's a lot lower than what it was before. As time progresses, progression of cardiac remodeling, the patient NYHA class function will deteriorate further. And if you can see here, these dips are all exacerbation, decompensated heart failure. And as the patient improves, it can never go back to the previous level, and eventually the patient will be NYHA class 4. Again, cardiac remodeling is associated with high morbidity and mortality. By the time the patient reach NYHA class 4, the heart function would be extremely low and the heart would be dilated. So how does remodeling associated with cardiac event? So this is a study that was done in 2008 under the Valiant Valsartan in acute MI, and this is actually a subgroup of patients of about 603 population. And this particular patient, they look at patients' echocardiogram, specifically looking at the LV mass and LV wall thickness. So if they divide the patient into 4 groups, one patient have normal cardiac geometry, another have concentric remodeling, eccentric hypertrophy, and concentric hypertrophy. So basically, this patient have a normal LV mass with a normal wall thickness, and in this case, the patient have a fairly normal LV mass, but the wall thickness has increased. And here, the patient have higher LV mass, and they started to have dilatation of the LV wall, and here the patient have increased LV mass as well as increased LV wall thickness. And if you can see here, patient who have normal cardiac geometry despite having post-MI, they actually have almost 0 risk of developing CV death, reinfarction, heart failure, stroke, sudden death, or other CV event. But as soon as a patient started to have any form of cardiac changes, remodeling, and if they have concentric hypertrophy, their incident rates of CV death, heart failure, infarction, and any other CV event has substantially increased. Now, why are we stressing on reverse cardiac remodeling in patients who have reduced heart failure, dilated cardiomyopathy? Simply because in reverse cardiac remodeling, the LV function will be increased. So meaning that the patient cardiac output will be better, patient symptom will be better as well. And patients sometimes can improve from NYHA class 4 to NYHA class 1. Again, the LV volume would be less both in systolic as well as diastolic. As the LV volume decreases, the left atrium volume index will be decreased as well, and there will be much less mitral regurgitation. And if you can see here, in cardiac remodeling, the patient's spherical shape of the heart will be reduced to a more ellipsoidal shape. But I must stress that reverse cardiac remodeling is a very dynamic process. It is not straightforward. It does not mean that somebody who have reverse cardiac remodeling is totally inverse or correct any defect of the heart, but it's actually more of like a process, an ongoing process that a patient need to continuously take the heart failure medication to ensure that the heart function continue to improve and the patient symptom continue to improve. Okay, what is a cardiac remodeling in heart failure? There's three major criteria. One of it in the left ventricular systolic function. So I'm sure everybody have heard from what Dr. Rafida said that the LV ejection fraction is one of the commonly utilized parameters that doctors use to look at the cardiac output or the pumping action of the heart. Secondly, it will be the volume, the LV volume, both in end diastolic as well as end systolic. Secondly is the shape and the function of the valve. The valve that we predominantly want to look at here is the mitral valve, okay? Certainly in dilated cardiomyopathy, the mitral valve annulus would be bigger and causing much severe mitral regurgitation. So of course, in reverse cardiac remodeling, the mitral valve would be much less. And secondly, not highly accepted, not practiced, I would say the word, would be an LV diastolic function. So basically this is looking at the E over E prime ratio. Now, which patient are more likely to undergo reverse or beneficial cardiac remodeling? So in this diagram, it clearly shows that patients who have ischemic, non-ischemic etiology have a much better chances of reverse remodeling compared to the ischemic causes. In this case, our female patient is an advantage over our male patient because female patients tend to do better in reverse remodeling. And heart failure duration is also important. So this is why we have to act fast and act soon, and we have to start our patient on the right medication right from the beginning, because if patient have heart failure duration less than 12 months, the chances of them recovering is much, much higher. And of course, lower ejection fraction have a better at reverse remodeling. Though I must say that low EF have a higher comorbidity, but somehow patients with poor LV function can have a much better reverse remodeling. And again, in patients who are lucky enough to have a cardiac MRI, those who have late gadolinium enhancement and would have higher chances of adverse remodeling compared to those that have no enhancement. And again, much higher biomarkers such as NT-proBNP or more than a few thousand, of course, have a much adverse remodeling significance. So this is the trajectory of a heart failure patient, EF changes in patients who are started with a heart failure treatment. So they are usually in the inverted U shape, okay. It improved initially, but over the couple of years, up to 10-15 years, it plateaus before it goes down. But if you divided this patient between the patient who have heart failure below 12 months and above 12 months, you can clearly see that those who have heart failure less than 12 months do much, much better than those patients who seek treatment a lot later, or heart failure treatment was not started more than 12 months after the onset of heart failure. We all know from what Dr. Rafida said that heart failure have high mortality, and this is largely due to this remodeling. So this is a meta-analysis of 85 heart failure therapies, 86 trials, sorry. And in this case, in this meta-analysis, they look at 3 types of patients who have neutral remodeling, meaning that no change from baseline. the dark blue is those patients who have a positive remodeling, and the pink dotted one are those patients who have negative remodeling or adverse remodeling. If you see in here, they look at the ejection fraction as well as left ventricular volume. Here is diastolic volume, and here is systolic volume. And if you can see here, those patients who have cardiac remodeling, meaning improvement of ejection fraction, have much lower risk of death, cardiac death, compared to those patients who did not have any change of ejection fraction. Again, in this case, those patients who have much less diastolic volume as well as systolic volume does a lot better compared to those patients who have no change in their left ventricular volume after starting medication. So again, what we know is that patients who have improve ejection fraction, reduce end diastolic volume, and as well as reduce end systolic volume does a lot better in terms of it reduce hospitalization rate and death. Okay, so this is a study looking at the LV structure and function compared to the anti-proBNP reduction. And you can see here, the patients are divided into 5 groups. So these are the patients who have fared so much better because they have change of anti-proBNP of more than 5,000 as compared to this in the blue category where they only have a change of less than 1,000. And if you can see here throughout this spectrum, looking at the EF and left ventricular and diastolic as well as end systolic volume, you can see a much higher change in a much higher reduction in anti-proBNP does a much significant favorable change in the echocardiogram of patient. So what are the other medical therapies that reverse cardiac remodeling? We all know since 1997 that the heart failure are actually neurohumoral mediated, in the sense that in these studies it shows that patients who have heart failure has significant neurohormonal changes, in the sense that they have much higher norepinephrine, they have much higher plasma reactivity, they have much higher arginine vasopressin, and as well a lot higher atrial natriuretic peptide. And based on this, in the last couple of years, this has been used as the hallmark treatment for heart failure. So this is the same diagram that Dr. Rafida have shown everybody. The neurohormonal changes in heart failure are mediated by these 3 pathways. One is the sympathetic nervous pathway. Second is the renin-angiotensin aldosterone pathway, and lastly in the peptide, natriuretic peptide pathway. So we all know all these 3 pathways had blockage that would help in terms of heart failure. So in this case, in the sympathetic pathway, of course, it causes vasoconstriction, which end up activating the RAS system. It also increases the heart rate and increase contractility. So all these are actually a response to improve cardiac function. Yes, initially at the short term, this response is very beneficial because it improves cardiac output, it reduces the failure symptom, and it really actually helps in terms of recovery. But sadly, over time, there is overfunction of this symptom, which then will end up causing cardiac remodeling. So that's why the sympathetic nervous pathway is blocked by the beta blocker. The RAS pathway blocked by the ACE inhibitor and as well as the ARB. Interestingly, there is a study that shows the aldosterone level of patient who has been on ACE and ARB can still be high in patients who have heart failure. This phenomenon is likely due to aldosterone breakthrough, and that's why has been recommended that the patient should be on MRA as well, mineralocorticoid receptor antagonist. And the most recent kids on the block is this dual inhibition of neprilysin as well as RAS. Of all these two, these will increase the cardiac output, but natriuretic peptide system is actually a counter-regulatory mechanism, in a sense that all these cause vasoconstriction, but the natriuretic peptide system actually cause vasodilation. So this is actually triggered by the cell in the myocardium, stretching of the myocyte, as well as the atrial, cause release of these peptides, which improve in terms of reducing blood pressure, reducing sympathetic tone, and eventually reducing the afterload. So end up improving the reversing the cardiac remodeling. So that's why in this new kid on the block, which is mainly called ARNI, there's a dual inhibition of neprilysin. So it inhibits the neprilysin, which reduce the degradation of the peptides, and also part of it is actually a Valsartan, which is an ARB, which act on the angiotensin receptor. So as Dr. Rafida has said, this dual simultaneous inhibition of neprilysin as well as the RAS has a complementary effect that eventually will reduce the ventricular hypertrophy and eventually reduce cardiac fibrosis and improve or reverse the cardiac remodeling. So we all know the Sacubitril Valsartan combination does reduce NT-proBNP, and we know this from the paradigm studies that Dr. Rafida have mentioned earlier, but we do not know what are the missing links. So how does all this actually reduce the cardiovascular disease, hospitalization of heart failure, and all-cause mortality? This is Sacubitril Valsartan meta-analysis as looking at the LV mass as well as the LA, left atrium volume. So if you can see here, both of which have those who have patient was started on post-ARNI have a much favorable, significant effect in terms of remodeling compared to the pre-ARNI stage. So that leaves with us what are the unanswered questions. How does we know that somehow the Sacubitril Valsartan have effect on the heart structure and function, but how does it affect the morbidity and mortality? So really the answer in cardiac remodeling, and this has been demonstrated in these two studies that was published last year. One of it is evaluate HF and the other one is proof HF. If you can see here, the proof HF basically looking at those function cardiac echocardiogram that we mentioned earlier, but in evaluate HF, they're mainly looking at the aortic characteristic impedance, which is really resistant in left ventricular cardiac output. However, in this, the results was natural, but I want to share with you the results that we found for the reverse ventricular remodeling. So this picture just to share with everyone that treatment of heart failure is very different from COVID-19 pandemic that we are all facing at the moment. In COVID-19, majority 80% of our patients would recover, hopefully within 2 to 4 weeks. But sadly, in terms of treating patients with heart failure, is a long, hard work process. So you need a lot of patience treating this patient. So in terms of proof HF and evaluate HF, they have about In between them, they have about 1,000 patients. So both of it looking at the NT-proBNP level and change in structural from baseline to 1 year. Interestingly, unlike the paradigm, all of it are outpatient patient, and majority of the patient, all of the patients are ARB naive, okay, which is unlike the paradigm. And in here, particularly, they are looking at the common cardiac remodeling criteria that what we have mentioned earlier, such as EF, left atrial volume, left ventricular volume, as well as diastolic function. So why do they need to do proof HF? Basically, there's a lot of unanswered questions with the paradigm trial. Paradigm trial did not have any cardiac remodeling data. They have very minimal correlation of biomarker changes. And also, they're very strict in paradigm. They exclude patients who did not have high NT-proBNP, more than 600. They also exclude patients who cannot tolerate full dose of Sacubitril, Valsartan. In real life, not all patients can up-titrate to 200 milligrams of Entresto. So that's why I found that this study is very, very interesting. And also, they're also looking at the patients who are naive to heart failure therapy, because in paradigm, they want patients who are already stable on heart failure medication. So they look mainly, the primary endpoint is look at proBNP, correlation between proBNP and remodeling, as well as this. This is the most interesting part. Not only they look at the proBNP and remodeling, but they also look at the specific subgroup of patients that's not represented in the paradigm heart failure trial. One of it is those patients who are new onset of heart failure, as well as on heart failure naive. Those who have fairly slightly raised NT-proBNP, who did not meet the paradigm heart failure inclusion criteria. And also, interesting, this is what I'm looking at, those patients who cannot tolerate doses of up to 200 milligrams. Immediately, within day 14, within 2 weeks, we can see significant changes in the NT-proBNP on patients started on post-ARNI. Interestingly, following paradigm study, there are hardly any Sacubitril Valsartan trial that is, what do you call it, that is a randomized control trial, because essentially it is not ethical anymore to stop patients from receiving this medication, because if you can see here, within a span of 2 weeks, patient NT-proBNP has improved significantly. This is looking at the primary endpoint, correlation between NT-proBNP as well as the cardiac remodeling from baseline to 12 months. So you can see here clearly there is negative remodeling, simply because as the NT-proBNP in patients get lower, the LV function get improved. Similarly, here in the volume of the left ventricle as well as left atrium, the correlation was a positive correlation, and all these I would like to share with you have positive value of have a significant p-value. So looking at the cardiac remodeling one by one, you can see here there's positive correlation right from 6 months to 12 months, and actually 25% of subjects experience an improve of LV function of more than 30% over 1 year duration. Again, the left atrial volume as well as the diastolic function have much improved as well. And if you can see here, this is looking at the subgroup of patients that are not available in the paradigm. You can see here, these are the patients who have new onset heart failure or ACE or ARB naive. And you can see within 12 months, there's improvement of left ventricular ejection fraction, and there's reduction in the left ventricular volume. Similarly, in patients who have BMP, anti-BMP that does not meet the paradigm inclusion criteria, so these are the patients who actually have borderline heart failure. And even with borderline heart failure, they have actually improved their ejection fraction and as well as improved the size of the left ventricle. And this is where I found most interesting, because it shows here, does not mean that you need to, of course, you need to improve, you need to optimize the Entresto dose, but if you can't reach the target dose of 200 milligram BD due to whatever reason, low BP, worsening renal failure, and etc., there is still significant improvement in terms of patient cardiac remodeling. Again, this is a very interesting data that I want to share with you. This is looking at 4 subset group of patients. So this y-axis looking at death and hospitalization, x-axis, in this axis looking at the level of pro-BNP. Towards the left, there is reduction of the level, and here looking at the volume of the heart. So on this trajectory, it means there's a reduction in the systolic volume. Clearly here, patients who have the lowest level of anti-proBNP with the highest reduction in the left ventricular volume benefit the most, because they have low death rate as well as heart failure hospitalization rate, as compared to those patients who did not have much improvement in the anti-proBNP as well as no improvement in the left ventricular systolic volume. It says here death rate of about 12%, but still, to me, this is still a good improvement, because if you remember earlier when Dr. Rafida was mentioning in her topic, is that the mortality rate of patients who have heart failure is about 50% within 5 years, and 25% of patients who recently discharged from hospital due to heart failure would be readmitted. So even this shown much improvement. This is looking at the adverse event. It's very similar to the paradigm studies. On a real life situation, yes, we are faced with hypotension, because it can cause significant hypotension to patient. When we start them on Entresto, they can become dizzy. Hyperkalemia and worsening renal function is what I'm quite worried as well. When I start patient on Entresto, I usually would see them again. If I start them on outpatient basis, I'll see them again in a 1 week or 2 weeks time to repeat their renal function, primarily to look at the creatinine, worsening of creatinine as well as potassium level. So again, this is similar data that we showed earlier. So in conclusion, anti-proBNP reduction associated with reverse improved cardiac remodeling, as well as reduced morbidity and mortality. I'm not going to talk much about the Malaysian CPG, simply because just to share with you that in all stages, Malaysian health ministry advocate on the use of ARNI and advocate on titrating dose of ARNI to the maximum tolerated dose. Okay. Lastly, I'm going to share with you some of my landmark cases. I don't want to share with you cases that other people have shown before. I just want to share with you what are my worry in terms of, starting patient with Entresto. One of it is patients who are small in size and with lower blood pressure. So this is a case of 36-year-old lady who actually presented to me with decompensated heart failure in January. She has a fairly short history of failure. Interestingly, she had thyrotoxicosis in July, and she also had osteosarcoma, which treated in 2003. She was in her secondary school at that time. So her right femur was partially removed, as well as the secondaries to the lung and the jaw. When she saw me, her weight at that time was 56 kilograms. She's a small lady. She's tachycardic and fairly lowish blood pressure. So once I started giving her Avilasib, her blood pressure dropped even lower. So you can imagine my predicament in starting this patient on Entresto. This is a baseline ECG. If you can see, the R wave is much blunted in this case. This clearly shows that there cardiomyopathy in this patient, and she's tachycardic as well. I did the thyroid function test because she had grave thyrotoxicosis a year earlier. CK-MB entropy is normal, but interestingly, look at her this is actually an anti-proBNP of more than 6,500. This is a chest X-ray, cardiomyopathy, dilated cardiomyopathy, together with a blunted costophonic angle, so she had pulmonary pleural effusion. She also had a mild ascites on her ultrasound. Her EF at that time was 36 to 40%. The LV was dilated, and she also had poor diastolic function as well as MR. Her angiogram was normal. I started her actually on Entresto 25 milligram, which is half a tablet at night time for about a week. I did it very slowly because the blood pressure dropped all the way down to 90 systolic. So gradually I titrate it. I think by the time in April, Entresto dose of probably about 50 milligram twice a day. So I was very cautious with her, going up very slowly. But this is the echocardiographic finding. So this is at baseline. On discharge, I started on 25 milligram of Entresto at night, and you can see here all these EF, the echocardiogram finding that we have collected show there is significant improvement post-ARNI, post-Entresto. So this is the ejection fraction, 30 to 40%. It went up to 50%. There's two types of way where we measure ejection fraction. One is the TAG method, and this is a SIN method. Both of which showed significant improvement. Again, the volume size of both diastolic as well as systolic volume has significantly reduced as well over time, over the span of 10 months. The diastolic function improved immediately within the span of 4 months. And this is the most interesting data that I want to show it to you. Her anti-proBNP started at 6,500. It went down to 1,000 plus and eventually to 700. So hopefully when I'm due to see her again in January, there will be further reduction in the ARNI. So this actually one of my hallmark case because I found that usually Entresto does drop the patient blood pressure, but if you start slowly and persistently, you can slowly up titrate. So now she's currently on 100 milligram of Entresto. She's a very active lady now. She take up badminton and play almost 2 to 3 times a week. And she has started hiking as well. So she has done very well. So another second case I want to share with you is an old man. So we all scared of starting an old patient, even on ACE and ARB. But I have no choice in this patient. He's a lovely old man. He's a widower with 5 kids. He lives in Sarawak, Kuching actually, but have moved to KL to be near her daughter recently over the past 1 year because of failure symptoms. So he had bypass in the past. He's your typical patient, hypertensive. He even had a stroke about a year before he was admitted to my hospital. And within this duration of 12 months, she has been hospitalized twice, twice in Kuching and twice in KL. So when she come and see me, He was recently discharged and have worsening edema, breathlessness, chest tightness, and these are her parameters. Sorry, her pulse is actually 100 beats per minute. Her BP is fairly lowish. He has failure in his lung. This is his chest X-ray. This is a post-bypass patient. You can see cardiomyopathy dilated, as well as blunting of costophrenic angle. His BMP, NT-proBNP at that time is 5,867. Even if you take into consideration his age, the BMP level is still very, very high. Ejection fraction was still very poor at 35 to 40%. They also have diastolic failure. This is his ECG. So I started this patient on IV LASIK and started him ever so slowly on Entresto because of his age, and I was worried of renal impairment, also the fact that the blood pressure is lowish. But eventually he was discharged when his failure settled. He has a very dedicated daughter, so they have been WhatsApping it in terms of his progress at home. So you can see here, I think this is within a few weeks of going back home. His Valsartan, this is a lung breathing parameters. He can start walking for about 5 minutes. His weight maintained, and he has improved over time. So I've increased, I think, his Entresto up to maybe 100 milligrams twice a day. His leg is much improved. So they took one picture of his leg. He was so proud of his leg because for the past 1 year before we start him on Entresto, his leg was like swollen like balloon. So you can actually see some crevices on his foot now. Within a month of going back, he actually can go to Surau. If you can see here, he's still live with his daughter. He can walk for approximately 50 meters. So he does this 5 times a day for prayers. So I'm very proud of him. Of course, this is all pre-COVID now. Nobody can do it anymore. If you can see the Valsartan, it has improved from 1,700 to the region of 2,004. So he's clearly much improved, and his weight continued to be the same as well. And this is a picture where he was celebrating his 90th birthday. So I decided to choose this patient to share with all of you, just to share that you can actually safely start Entresto on elderly patient, provided you start slow and steady and monitor them closely. And this just showed to me that, yes, when we treat somebody, we want to improve their mortality, morbidity, but looking at your patient able to go home, able to celebrate their 90th birthday with their family member at home is very satisfying. He eventually went back to Kuching and no longer under my follow-up, but I'm glad we started on Entresto. So thank you very much. This ends my talk for today.
Thank you, Dr. Ika, for such an interesting and great talk. So right now we'll move on to the Q&A session, and if it's possible, if the organizer could flash up the question. So for the first question,
who wants to answer this?
Well, you can answer that, Ika, if you want.
Yeah, I actually, yeah, certainly. Question number 1 is yes, for both me and Dr. Afida, we agree that we start Entresto.
Say yes to that.
Yeah.
Because usually what you do is that once a patient is out of the acute decompensated heart failure, what you do is that you will titrate up all the medications, and one of the medication that you would start for the patient will be Entresto. Again, if let's say the patient has heart failure reduced ejection fractions and you are seeing the patient in your clinic in the community, if let's say the patient has NYHA class 2 to 4, ejection fraction probably about 35-40%, you can consider the patient to initiate the patient on Entresto. in the community, I think it's better for you because the patient's house is usually near to your GP practice. What you can do is that probably you can see the patient back after 2 weeks. You need to monitor the potassium, as well as you can actually titrate up the dose afterwards. Ideally, you should titrate up to 200 milligrams per day, but as the data has explained earlier on, sometimes it's quite difficult, so you have to make do with what you have.
Dr. Rafida, so
Yeah, I
apparently the
totally
second
agree with
question,
Dr. Rafida.
Okay.
yeah, apparently the second question is rephrased to the third question. So the third question is on Dr. Gregory, and I'm rephrasing the question above. How often should an echo be done for a patient with heart failure reduced ejection fraction and current ejection fraction of 33%?
The question is that whether it's a new diagnosis or not. So basically, for example, this patient just had a recent MI and then the ejection fraction is low, then what you need to do is that you need to titrate up the medication, make sure that all the medication are titrated up, and then after that you can repeat the echo at 3 months. So this is to see whether or not the ejection fraction is still low, which means that it's less than 35%. Then if let's say it's still less than 35% despite optimal medical therapy, you need to consider the patient for ICD or CRTD, depends on what is the QRS complex durations. But if let's say this is an old patient who has had the ejection fraction of 53% for the past few years, my practice would be already optimize all the medication. Then I usually would repeat the echo every year for this patient. Again, as I said, it depends on the context. If it's new, then you have to repeat at 3 months to see whether or not there is any improvement. If I say there is no improvement, you may try to titrate up the medication again and then repeat at after 3 months after that. If let's say there is no improvement, you probably need to refer for ICD. But before you kind of implant the ICD, we usually would do kind of MRI beforehand just to get the accurate LVEF assessment. Ika, if you have any addition input on that?
Yeah, I don't normally repeat the echocardiogram too soon simply because it will be demoralizing.
Yes.
If there's not much changes, but certainly I prefer to do BNP more often because it will help in terms of titrating my heart failure medication.
Okay. Thank you, Dr. Ika. Speaking of BNP, right, the third question is asking about if it's possible that we could use BNP in end-stage renal failure patient. So maybe Dr. Ika, if you could enlighten us if BNP is able to use in end-stage renal failure patient, and what are the contradictories or pitfalls that we need to take note when using BNP?
Yeah, BMT is not advisable to be done in end-stage renal failure simply because it's excreted to the renal, so it will be exorbitantly high BMP level in patients who have end-stage renal failure, so it's not feasible. So in this case, I would recommend, we have actually started on some patients who are on end-stage renal failure on regular dialysis on Entresto. So what I do normally is look at their clinical symptom and titrate according to their hemodynamic and blood pressure during dialysis as well as in between dialysis. So I don't use BMP. And certainly we use echo to monitor their function.
Sure. Speaking of echo, we're moving to number 6. Please elaborate again the 2 types of echo done to measure ejection fraction.
So, okay. Dr. Rafida can answer this.
Okay, it's not really 2 types of echo. Basically, when you do the echo, so what you need to do is that you need to measure the ejection fraction using the biplane measurement rather than using, because there are a few types of measurement of ejection fraction. In the old time, we use the type, which is actually the 2D dimension. You just measure that, but the problem with that is that you're only looking at one plane. So if, let's say, for example, the kind of basal septal wall is okay, but then the apical is actually severely hyperkinetic, you would actually get the wrong ejection fraction. So when when you do the biplane synchrone, what you're doing is that you're looking at the heart as an ellipsoidal. So basically, you're actually kind of getting a proper or more accurate ejection fraction. I don't think that there are two types of echo. When we do the echo for patient with heart failure, what we want to know is that one, we want to see whether or not there is any reduce in ejection fractions, because we want to quantify whether or not they are heart failure preserve, mid-range or reduced ejection fractions. And then you want to see whether or not there is any kind of problem with the valve. So you want to see whether or not there is any valvular regurgitation, because usually if they say you have severe mitral regurgitation or severe aortic regurgitation, you can also, you usually would present with heart failure symptoms. And then the third thing is that you usually would want to see what is the LV size, whether or not it's normal, mildly dilated, moderately dilated, or severely dilated. And the next thing that you want to see is that you want to see what is the diastolic function. Okay, because if they say the patient has normal diastolic function, usually they won't have kind of heart failure symptoms. In general, if they say the patient has heart failure symptoms, they need to have at least a stage 1 or stage 2, or even worse, sometimes stage 3 diastolic dysfunction.
Thank you, Dr. Rafida. So the last question is, what is the role of SGLT2 inhibitor in heart failure patient? So maybe perhaps Dr. Ika, you could help us to enlighten us with this question.
Okay, I'm a strong supporter of SGLT2 inhibitor, I must say, but in the context of patients who have diabetes as well as heart failure at the same time. But I don't use it on patients primarily who have heart failure without diabetes, because we all know that diabetes is a chronic disease that affects the cardiorenal syndrome. So their studies have shown that they have a good effect in terms of the cardiac as well as renal comorbidities in patients, especially so in patients who have heart failure. So I don't just use it on patients who have heart failure.
Thank you, Dr. Ika. So we have come to an end of our event today, and my apologies for the slight delay. And on behalf of Novartis, I'd like to thank both our speakers, Dr. Rafida and Dr. Ika, for their effort in putting in such a great lecture for us, and also for all the attendees. I wish you have a great evening. Thank you very much.
Yes. Okay.
Have a good evening.
Bye.
Thank you. Thank you.